Hello, I'm Dr. Guagliumi from Ospedale Papa Giovanni, Bergamo, Italy. Happy to be with you tonight at this cardiac injury and PCI virtual meeting in the era of COVID-19. 1,000 patients with ACS were missed out on life-saving treatment since the start of the COVID-19 outbreak. It was truly an obstacle course to try to get reperfused of these patients. The most efficient EMS were flooded by calls of patients in severe respiratory distress. During a 40 days period starting on February 23rd, my hospital admitted more than 1,400 patients with interstitial pneumonia, and hundreds of them were requiring ETI or advanced ventilatory support. The network was completely disrupted. No chance to get in contact with your doctor. The phone lines were saturated. No chance to have one ambulance. And then a major obstacle in transferring the patients to the hub center, in wearing the PPI, and then again in deciding which type of therapy. There is a clear evidence recently published in the literature that the coagulopathy is associated to an endothelial pathology in COVID-19. Here you can see the vulvilabrant antigen activity and the factor A activity in COVID-19 patient hospitalized in the ICU and non-ICU department compared to the normal range. Incredible augmentation of a coagulation factor and changes in spontaneous fibrinolytic. What about the injury? Well, we know that in COVID-19 infection, myocardial injury is quite frequent, but for the vast majority is very mild or moderate in entity, with some exception. And the exception is not only having an incredible risk if you have a cardiovascular disease or if you have a cardiovascular risk factor, but also in patients that do not have neither cardiovascular disease, neither risk factor, when you are increasing the troponin level significantly, you might have an incredible increment of the hazard ratio. Meanwhile, we were exposed to the data that were showing as in STEMI patients with COVID-19, a quite a significant percentage of these patients arrive with a non-identifiable culprit lesion, so apparently normal epicardial coronary vessel. And the outcome was absolutely not favorable, and it was associated with a reduction of the left ventricular ejection fraction. For this reason, we focus in co-sharing with the CV-PAT and Dr. Thin and Virmani on the cardiac injury in COVID-19 as a pathology systematic analysis study. All the heart obtained autopsy from Bergamo were transferred to the CV-PAT to be deeply analyzed. What we had, number one, we had patients coming to us. This is a case, lady, 43 years old, no cardiovascular risk factor. She was assisting her husband who was hospitalized for COVID-19 interstitial pneumonia the same day when she was starting to suffer chest pain. ST segment elevation in the inferior and lateral lead. She was quickly transferred to our hub. Then she was arriving clearly hypotensive and tachycardic with a very significant low ejection fraction with akinesia at the level of the inferior and lateral wall and some pericardial effusion. Put on the table immediately to check the coronary artery. The coronary arteries looks normal at the epicardial level with some persistent blush at the level of the distal right coronary artery. So we support immediately here by using intra-aortic balloon pump and inotropes. Here you might see the chest X-ray where there was a redistribution toward the apical part of the flow, but no interstitial pneumonia. She was tested positive to the nasopharyngeal swab immediately performed, and she was transferred to the ICU. Here you have all the essential information, including the hours after the hospitalization, then the vital sign, then the lab data. As you can see, this situation went quite quickly in the wrong direction, despite the inotropes and the intra-aortic balloon pump support. She was becoming systematically hypotensive. So because she had a normal coronary epicardial vessel, we were thinking about a myocarditis. So we treat here by using duronavir and a high dose of methylprednisolone and immunoglobulin in infusion with escalating dose of inotropes, and she was quickly deteriorating in terms of lactates, in terms of multi-organ failure. Quite important to understand that the coagulation system in this lady who came with the diagnosis of STEMI was completely changed with a significant increase in prothrombotic fragment F1 plus F2 and the von Willebrand factor, as we previously mentioned, but also a dramatic increase in the inhibitors of pi. And she died in 46 hours. So this is the pathology assessment, then the CV part. So from a macroscopic point of view, you might see there were regional myocardial infarction on the lateral wall, inferior wall, extended to the inferior wall, also to the right ventricle. This patchy myocardial infarction was extending from the endocardium to the epicardial with contraction band, with some inflammatory infiltrates, but very relevant. All the small vessels were filled by fibrin-rich and platelet-rich thrombi, as was documented by this positive CD61. And they had immunofluorescence. The vessels were positive for VE cadherin, one endothelial marker, and positive also for CD61, CD42, that is a platelets marker. What about PCR IL-6? So we searched systematically in the entire heart, and you can see that was clearly detected at the level of the inferior wall of the right ventricle, inferior wall, and with some involvement on the septum. The lungs show some pulmonary edema with a microthrombi, and so microthrombi were diffusely observed at the level of the kidney and the level of the spleen. No virus was detected inside this heart. So the major message from this clinical case is don't mistake microthrombi for myocarditis in COVID-19 patient presenting apparently with STEMI. And I think the major conclusion is the case challenge the traditional differential diagnosis of STEMI in the setting of COVID-19 and reveal the potential for microvascular thrombi in absence of epicardial coronary artery disease to be responsible for acute myocardial infarction. So new therapeutic options needed to be explored for these microthrombi. They are observed at the level of the multi-organs. Thank you very much for listening to me.